I spent much of my career cutting into the body, into disease, into a future a patient feared was already decided. But the future of medicine may be defined by the moment we no longer have to cut at all. A weekly injection that changes the trajectory of metabolic disease. Focused sound waves that break apart a tumor without an incision. A heart valve replaced without opening the chest. This was never just about obesity. Medicine is learning to cut the knot. Welcome. I'm Dr. Robin Blackstone. Today we are going to follow a pattern across obesity, cancer, cardiovascular disease. A pattern that is changing not only how we treat illness, but how we think about intervention itself. This was never just about obesity. Medicine is learning to cut the knot. Recently, a patient with a liver tumor lay still on a table while a focused beam of sound destroyed the tumor from outside the body. No incision, no treatment needle, no radiation. The technology is called histotripsy. It uses focused ultrasound to create microscopic bubble clouds that mechanically break down targeted tissue. One recent patient was home and back to normal activities the same evening. The FDA authorized the Edison system in 2023 for the non-invasive destruction of liver tumors. More than 1,000 people have since undergone liver tumor procedures with the system. And in May, its manufacturers submitted a request to expand the indication to kidney tumors. Long-term cancer outcomes are still being studied, and that matters. But so does the shape of the advance. A treatment that once required entering the body can now, for selected patients, be delivered from outside it. I have spent my career as a metabolic and bariatric surgeon, and I want to tell you that this story is not really about a machine. It's about a pattern. And once you see it, you cannot unsee it. The knot. In 2019, in the Bulletin of the American College of Surgeons article, Surgery and the Gordian Knot of Metabolic Syndrome, my co-authors and I described metabolic syndrome using an image from antiquity, the Gordian knot. Obesity, type 2 diabetes, hypertension, dyslipidemia, fatty liver disease, polycystic ovarian syndrome, and some cancers have been divided into separate specialties, separate appointments, separate drugs, and separate payment streams. Medicine spent a century trying to untie the knot one strand at a time, managing each consequence after it appeared, often for the remainder of a patient's life. Our argument was that these were not simply independent failures occurring in the same body. They were often connected manifestations of a shared metabolic pathology. A disease decisive intervention at the mechanism could change several strands at once. Metabolic surgery had already demonstrated the principle. In one long-term prospective study, Roux-en-Y gastric bypass produced durable weight loss and type 2 diabetes remission in approximately half of affected patients at 12 years. Surgery did not merely make the stomach smaller. It changed metabolic signaling, appetite regulation, and the body's defense of weight. But the country was not ready to hear what the biology was saying. Surgery was called extreme. Obesity was still treated as a failure of discipline. Patients were told in one form or another that the knot was their fault. Then the GLP-1 drugs arrived, and something changed that had never changed before. The number that had never moved. In July 2026, Gallup reported that its measure of U.S. adult obesity had fallen from a peak of 39.9% in 2022 to 36.4% in 2026, while the share of adults reporting current GLP-1 use for weight loss rose from 3% in 2024 to 11%. These are self-reported survey data, not measured national examination data, and parallel trends alone cannot prove that the drugs caused the entire decline. But Gallup has used the same method over time, and the direction is statistically meaningful. After decades in which the curve seemed capable of moving in only one direction, it moved in the other. No lecture about personal responsibility accomplished that. A class of molecules helped make it possible. The drugs did not solve the biology, they solved the politics. Metabolic surgery had demonstrated the biology decades earlier. The drugs made that biology culturally negligible. A weekly injection made it finally sayable at scale that obesity is a chronic biological disease, not a referendum on character. That was a therapeutic breakthrough, and it was also a political one. The pattern is bigger than obesity. The obesity story is the loudest incidence of something happening across medicine. Look at the shape of it. In liver tumors, focused sound can destroy targeted tissue without an incision. Kidney tumors may be next. To orient you to where the field stands as of July 2026, histotripsy is authorized for clinical use in liver tumors. Kidney tumor treatment is under FDA review following a pivotal human trial. Pancreatic and selected abdominal tumors are being studied in early human trials. The prostate study involves benign prostate enlargement, not prostate cancer. Work involving tumors in the lung, brain, and bone remains limited or preclinical. And an important caution, a human study does not mean that a treatment is approved, proven, or appropriate for every patient. In severe aortic stenosis, a new valve can be delivered through a catheter rather than through the open chest. In selected patients, randomized trials have found comparable major outcomes between transcatheter and surgical valve replacement through 5 and 6 years, even as questions of lifetime durability and reintervention remain. In some advanced cancers, immunotherapy has produced durable survival, and for a subset of patients, something approaching long-term disease control, where survival was once measured in months. For some patients, managing cancer as a chronic disease is now current therapy, preventing more cancers from developing at all, and intercepting others before they become clinically apparent is the horizon we can already see. In hepatitis C, 8 to 12 weeks of oral medication now cures more than 95% of patients, where medicine once waited for cirrhosis, liver cancer, or transplantation. Put these examples side by side. In metabolic disease, surgery and GLP-1 therapy alter metabolic signaling upstream. In liver tumors, histotripsy, the selected target without an incision. In severe aortic stenosis, TAVR delivers a new valve through a catheter instead of an open chest. And in hepatitis C, direct-acting antiviral medications cure the infection before cirrhosis, cancer, or transplantation develops. The structural move is the same. Pull disease upstream of rescue. Stop paying forever for the consequences when a precise intervention can change the mechanism. Stop untangling the knot. Cut it. The honest part. None of this is free, and I will not pretend otherwise. My own field sometimes dismisses the medications by saying that when patients stop taking them, weight often returns. That's true, but surgery is forever too, and so is a surgical complication. Stopping a drug is a decision a patient may be able to revisit next month. A stricture, leak, nutritional injury, or chronic complication may not be reversible. Medication carries its own risks, costs, and uncertainties. Metabolic surgery has unmatched durability for many patients and a long evidence base, but it also asks the patient to accept an irreversible intervention. When timing is crucial or disease severity demands a decisive intervention, surgery may be the first option. In most other cases, it should follow a fair trial of medication and comprehensive non-surgical care, fairly offered, adequately supported, and not declared a failure simply because coverage ran out, especially when the patient achieves their weight loss goal, and then the maintenance doses of medication are no longer covered. Histotripsy is genuinely non-invasive, but it is new, not appropriate for every tumor or every patient. Its long-term oncological role is still being defined. TAVR avoids a sternotomy, but age, anatomy, valve durability, and future procedures still matter. Every advance carries a ledger of risk, benefit, durability, and reversibility. The honest clinician puts both columns on the table. Then the patient, the evidence, and the biology choose together. The human principle, the person whose life and health are actually at stake, carries both the authority and the responsibility for the decision. That honesty is not a brake on innovation. It is what earns the trust innovation requires. Why this is a systems story. When a decisive, less invasive treatment exists, but patients cannot reach it, the remaining barrier is no longer scientific. It's architectural. We built a health system that pays in perpetuity for the consequences of disease: insulin, dialysis, repeated admissions, complications, and rescue, or death. At the same time, it places interventions that may prevent those consequences behind coverage cliffs, pre-authorization mazes, fragmented benefits, and geographic treatment deserts. That arrangements made a grim kind of sense when decisive options did not exist, but increasingly they do. Keeping the old payment and delivery architecture in place is now a choice, and a very expensive one. This is the heart of what I mean by Health 4.0, a system organized around prevention, early detection, and durable treatment at the level of mechanism, delivered through the precise intervention that fits the person. Sometimes that intervention will be behavioral, sometimes pharmacologic, sometimes surgical. Sometimes it will be a beam of sound delivered from outside the body. The point is not that one tool wins. The point is that the system must stop forcing every patient through the same door. Type 2 diabetes, hypertension, dyslipidemia, fatty liver disease, PCOS, obesity-associated related cancers, depression, and disability. I will place the surgical and pharmacologic evidence side by side, including what works, what fails, what lasts, what reverses, and what we still do not know. This is not an argument for surgery over medication or medication over surgery. It is an argument against making patients wait for rescue because the system is more comfortable paying for consequences than changing mechanisms. Alexander the Great understood something medicine forgot for a century. Some knots are not meant to be patiently untied. They are meant to be cut. Across medicine, we have finally begun to build the swords. The question now is whether we will build a system with the courage and the honesty to use them. This essay begins a series called Cutting the Knot. In the episodes ahead, I will take the metabolic knot apart strand by strand. I will place the surgical and pharmacological evidence side by side, including what works, what fails, what lasts, what reverses, and what we still do not know. Where are you seeing this shift in your own field? What disease are we still managing strand by strand when we should be changing the mechanism? The complete essay, figures, evidence, and source links are available in the accompanying Substack post and in the show notes. I'm Robin Blackstone. Thank you for listening.